Hello, my name is Shane, and our group would like to begin by introducing our evidence-based practice project. Our project encompasses the topic of Alzheimer's disease and treatments that are utilized for the disease. Before getting into the nitty and gritty though, I would first like to begin a discussion by asking, well, what is Alzheimer's disease? Alzheimer's is a slow fatal disease of the brain affecting 1 in 10 people over the age of 65. Globally, 49 million people are affected. No one is immune. The disease comes on gradually as two abnormal protein fragments called plaques and tangles accumulate in the brain and kill brain cells. They start in the hippocampus, which is a part of the brain where memories are first formed. Over many years, the plaques and tangles slowly destroy the hippocampus, and it becomes harder and harder to form new memories and simple recollections from a few hours or simply a few days ago that the rest of us might take for granted and just aren't there. After that, more plaques and tangles spread into different regions of the brain, killing cells and compromising function wherever they go. The spreading of plaques around is what causes the different stages of Alzheimer's disease. From the hippocampus, the disease spreads to the region of the brain where language is processed. When that happens, it gets tougher and tougher to find the right word to say. Very gradually, a person begins to lose the ability to solve problems, grasp concepts, and make plans. Next, the plaques and tangles invade the part of the brain where emotions are regulated. When this happens, the patient gradually loses control over their moods and feelings. After that, the disease moves to where the brain makes sense of things it sees, hears, and smells. In this stage, Alzheimer's disease wreaks havoc on a person's senses and can spark hallucinations. Eventually, the plaques and tangles erase a person's oldest and most precious memories which are stored. Near the end, the disease compromises a person's balance and coordination, and in the very last stage, it destroys the part of the brain that regulates breathing and the heart. The progression from mild forgetting to death is slow and steady and takes place over an average of 8 to 10 years. It is relentless and for now, unfortunately, incurable. Helping your family, friends, and neighbors to better understand Alzheimer's disease will reduce stigma, improve care, and even help the fight for a cure. Continuing on, I would like to state our group's PICO question prior to our research. Our PICO question is, an adult over the age of 60 with Alzheimer's disease/dementia, does music therapy combined with pharmacological interventions compared to only pharmacological interventions help improve quality of life over 6 months?
Thank you, Shane, for sharing. My name is Josie, and I will be introducing article number 1 to you, which was Alzheimer's Disease and Music Therapy, an Interesting Therapeutic Challenge and Proposal, written by the authors there listed on the poster. The purpose of this article is to highlight the effectiveness of music therapy in patients with Alzheimer's disease already under pharmaceutical care. This is a level 2 study, and it was a retrospective study. The sample included 32 patients with an active diagnosis of Alzheimer's disease according to the ICD-10 code criteria. 17 women and 15 men were selected between the ages of 54 to 81 with a mean age of 67 and a half years old. These patients were also receiving medications such as antidepressants, rivastagamine, or donepezil, or a combination, for 6 months before and throughout the study. The selection of the participants was random regardless of life, social, educational level, and concomitant disease. So the methods used to collect data were prior to implementing musical therapy as a form of treatment, researchers obtained a medical and social history as well as patients' music profile through a music therapy questionnaire. The music therapy sessions were then incorporated and consisted of a musical theme closely related to the patient's music profile. The sessions were implemented 3 times per week, either in individual or group sessions, lasting no longer than 1 hour. The sessions included listening to music, songs, improvisation, listening to music, and talking. After 6 months of music therapy sessions, patients' mental function was assessed using the Mini Mental State Examination Questionnaire, which is the MMSE, in patients with mild, moderate, and severe Alzheimer's disease. This assessment examined patients' orientation, engraving, attention, and arithmetic, recall, and language, which assists in classifying patients with either mild, moderate, or severe Alzheimer's disease. Now the results. Patients with severe Alzheimer's disease showed a significant change by a reduction in severity of about 50% from the initial assessment. Some of these patients even moved to the stage of moderate Alzheimer's disease after the intervention of music therapy. There was an increase in patients with mild Alzheimer's disease, but that is due to the improved mental function after music therapy in patients who were classified to have moderate Alzheimer's disease initially. There was a 12% decrease of patients with moderate Alzheimer's disease after music therapy, which also shows a significant benefit from the intervention. Overall, this research is directly related to our PICO question because it focuses on the effectiveness of a non-pharmacological intervention, which is musical therapy, to improve patients' mental function and overall quality of life by reducing the severity of their disease.
Thank you, Josie, for reviewing article number 1 for us. My name is Ian, and I'll be introducing article number 2, Combining Drug and Music Therapy in Patients with Moderate Alzheimer's Disease, a Randomized Study. This article is by the authors listed on the presentation. So the purpose of this article was to analyze the effects of active music therapy in memantine, or on communication, mood, and quality of life in patients with Alzheimer's disease. Memantine is an Alzheimer's disease drug. It's a pharmacological intervention, and that's just comparing the combination of active music therapy. So what type of study is this? This is a level 2 study in accordance with Winona University's level of studies chart. And why is it a level 2 study? It is a computer generalized randomization. So the pool of 45 patients were put into a computer, and this software generated randomization and assigned the patients and the sample to their according groups. So what's the description of the sample for this study? 45 patients, they all have Alzheimer's disease. The control group was composed of 22 patients. These patients' intervention was on memantine, so just the pharmacological intervention. And then the intervention group were 23 patients on memantine and active music therapy. So that's where the combination occurs. 23 people had the non-pharmacological intervention along with the pharmacological intervention. So what data collection tools and methods did the researchers use to, conduct this study? They used SAS software, mini mental state examination, analysis of covariance, an X-squared test, and then a severe impairment battery language test. These data collection tools assess the patient's mental status, analyze the study for covariance, and then the severe impairment battery language test analyze the communication skills and quality of verbalization in the Alzheimer's patients. So what were the results of this study? Well, evidence suggests that significant benefits are found in memantine and combined with active music therapy. So this evidence suggested that after 12 weeks, there was an improvement for depression and appetite disorder, and after 24 weeks, there was only an improvement for depression. So memantine and active music therapy are associated to improve psychiatric symptoms. And this is in comparison again to the drug therapy alone. Although at the end, we did find out that specifically in regards to language, evidence suggests that adding music therapy to pharmacology, that combination, does not necessarily improve communication. So in relation to our PICO question, population intervention comparison outcome time, it correlates with the PICO through the case study emphasizing the effectiveness of the music therapy. This in combination with pharmacological interventions have been shown to improve quality of life in the patients and in some instances the caregivers, but that's not necessarily in our presentation, but it definitely did improve the quality of life for these patients with Alzheimer's disease.
Now that we've had an opportunity to discuss some of the articles that we've used within our project, I want to highlight some considerations, and I'm going to start with family education. I think the big thing here is safety, focusing on safety. So we're going to make sure that we're instructing family to lock doors, removing safety hazards so that so that these patients with dementia don't trip. We want to keep things in plain sight. It's important to use memory training activities and aids so that these patients with early stages of dementia can maximize their cognitive functioning and independence, and it'll kind of slow that progression of the disease. When other resources such as pharmacological interventions have been exhausted, it's important to not forget about some alternatives such as like massage, aromatherapy, music and dance therapy are really good ones. There's animal-assisted therapy and multisensory therapy. In reference to staff education, the big thing here is instructing staff to speak clearly, slowly, and using short sentences. Making eye contact with the person when they're talking or asking questions is a huge one. It's important that we're not pressuring the dementia patients to respond because we might be overloading them with too many options. So we want to give them time to respond that way, and just be cognizant of not trying to speed up their answers. In reference to ethical and legal considerations, we just want to make sure that, we're respecting the patient's belief because they might not have the cognitive ability to stand up for themselves when making a decision. So we need to take that into consideration, whether that's a guardian of the patient or even a provider who has a good rapport with the patient and was more familiar with them before their cognitive decline. But an ethical issue that I think is interesting with dementia research is that persons without supportive family or they may be excluded from research and its benefits because they truly lack adequate representation. In regards to cultural considerations, interestingly, white Americans make up the majority of over 5 million people in the United States with Alzheimer's disease. But combining evidence from a lot of different studies actually highlight that African Americans and Hispanics are at higher risk. Truly, dementia just does not discriminate, and there are so many individuals globally diagnosed with Alzheimer's disease. As for financial considerations, these clients really do lose their ability to handle their finances. So ideally, when you have a dementia patient with their family, their family is managing their finances. And it truly does tear families apart financially because it's such an expensive disease, because they're spending so much money to care for their family members with dementia. There are a lot of different resources available in communities. Alzheimer's Association is a great one. There's so many different chapters throughout the U.S. in each state, and there's a 24/7 available hotline. There's also Alzheimer's and Related Dementia Education and Referral Center, and I have provided a phone number in our pamphlet that you can reference, as well as an email if anyone has any questions. In reference to interprofessional collaboration, there's so many different team members that have different roles that are on the team. So whether that's a neurologist, nurse, social work, even personal support workers and family, they're doing so much to care for these dementia patients.
Thank you, Shane. This is Stephanie, and I'm going to be talking about critical thinking in application to Alzheimer's disease. Alzheimer's disease, as we know, is progressive and non-curable. The research that we found would allow nurses to have the best updated evidence and interventions like musical therapy. Our goal in healthcare is to improve patient care, but also to keep updated with new practices and new interventions due to healthcare constantly changing. In our first article, the results showed that patients with severe AD benefited from the treatment. This was shown by a reduction of severity by 50% in the participants of the study. On the contrary, our second article, there wasn't an evaluation of the severity in AD, but rather focused on the psychiatric symptoms that ultimately improve quality of life. To wrap this up, our PICO question was concluded to be met. Both of these articles that we chose compared musical therapy to some kind of form of pharmacological treatment, and they really highlighted the positive effects that musical therapy has on patients. Thank you so much for taking the time to listen to our presentation.